of positive cases has become a cause of concern, and therefore we cannot ignore it. I'm saying this because on Wednesday this week, on the 17th of August, we got a report from the NICD, NHLS, that we've had our fifth, number 5, positive case of monkeypox, which was a 28-year-old male from Johannesburg, Gauteng, with a travel history of Europe, Netherlands, and also it looks like it might have touched in Spain as well. The case was confirmed through a private laboratory, and samples were also sent to the NICD for sequencing. Now, this means that, as I said, we have recorded 5 positive cases between June 22 to the 17th of August, just 2 days ago. But there is no link at this stage, as the link has not been established with all these cases. But the team is still trying to check whether the last 2, the number 4 and 5, might have a link, because both had traveled to Europe, and it looks like to Spain, amongst other countries. We know that Spain has already recorded more than 5,000 positive cases and 2 deaths. Now, case 1 was recorded on the 22nd of June from a 30-year-old male residing in Johannesburg in the Gauteng province with no recent travel history, but who had presented with symptoms of monkeypox, and when tested, it was confirmed that it was monkeypox. The second case was recorded on the 28th of June from a 32-year-old male residing in the Western Cape province. Again, here there was no recent travel history, but presented with symptoms, and when the laboratory test was done, it was confirmed. Now, in as far as the third case is concerned, was recorded on the 10th of July from a 42-year-old male tourist from Switzerland visiting Limpopo province, also displaying the symptoms, and when the test was done, he was found to be positive. The tourist has recovered and has subsequently left for his home country. Now, the fourth case was recorded on the 14th of August from a 28-year-old male in the Western Cape. I've already referred to the similarity with the 5th case, who had recently traveled to Spain and presented with symptoms suggestive of monkeypox. The test confirmed positivity. Now, I need to mention that that's far. I've already mentioned about the tourist who has already returned back. All the 3 other cases have been mild and recovered, and also the 5th one, as far as we are aware at this stage, is very mild symptoms, but confirmed by laboratory. So, while the World Health Organization has not recommended any travel restrictions, but it is important that people who are traveling should exercise maximum caution. Now, in terms of there's a lot of questions just in terms of how the monkeypox is transmitted. It does involve person-to-person transmission, close contact, or infected materials contaminated by an infected person. Although the data just shows that most of the cases have been some form of sexual contact, sexual partners, but it can transmit to anybody as a result of close contact with somebody who has been infected with the monkeypox virus. Now, in terms of the vaccination, there is currently no specific vaccine for monkeypox in our country. There are vaccines which have been confirmed in the world. There are 3 main vaccines worldwide for the prevention of monkeypox. Quite some complicated scientific names, but there are 3 of them. One branded as Imavac in Europe, and the third one is called LC16M8. Now, so these vaccines are available in the world, but at this stage, we don't have any of this registered in South Africa. So monkeypox is a similar virus to smallpox. And South Africa has stopped smallpox vaccinations around 1982. As I've said, smallpox was eradicated more than 40 years ago, when the global vaccination campaign came to an end due to successful eradication of smallpox. Since then, there have been no smallpox vaccines offered to the general population, and smallpox vaccines have not been included in our expanded program on immunization in South Africa. However, most people who are over 40 years of age probably would have some form of immunity from the earlier vaccination for smallpox. So, because of that, we hope that they will also have a form of immunity to monkeypox as well. Now, SAPRA has indicated in June this year that there are currently no smallpox or monkeypox vaccines registered in South Africa, and that we also don't have very specific registered antivirals for monkeypox. And they also indicated that they don't have any applications in as far as registration for monkeypox vaccination and antivirals in the country. Now, according to the report from the World Health Organization, there are currently a total of 28,000, just over 28,000 cases, with 11 deaths from the monkeypox. The scientists have advised that at the current moment, there is no need for mass vaccination because the situation remains under control. But what I need to indicate, therefore, is that while this is the case, we are monitoring the situation, working with our scientists, and we will be asking our Ministerial Advisory Committee on Vaccination also to weigh into this and advise us in terms of what the situation should be, monitoring together with the NICD, and at the appropriate time with the advice also from VMAC, from the Vaccine Ministerial Advisory Committee, we will be able to, and of course also based on advice also from SAPRA in terms of if any of the vaccines are get registered in South Africa, remembering that for the vaccines and antivirals to be registered, a manufacturer or a pharmaceutical company would have to apply to SAPRA for the registration. So those are that's the situation currently. It's not that we don't want to consider, at the population at risk in terms of vaccination for monkeypox, but we are looking at all the facts. Firstly, that there must be one of the vaccines registered in South Africa, and secondly, also looking at the advice from WHO in terms of the population at risk. And so, as I've said, we will be depending also on the VMAC to give us advice. Just in terms of where we are currently with the COVID pandemic, I've mentioned in the beginning that we lifted all restrictions just around 2 months ago. I think two days from now will be full 2 months. Now, since we lifted the restrictions because infection numbers were very low, high levels of population immunity, and sustained decoupling of the infection rates, even when there was a small fifth wave, the decoupling between infection rates and severe illness continued, with very few people being admitted to hospital and even fewer needing ICU treatment. Now, since the lifting of the restrictions, the rate of testing, in other words, people presenting with symptoms for needing tests, cases, hospitalization, and also deaths have all continued to decline. Now, we believe this is an indication that we acted in the right public interest, because up to 2 months now, we have not seen any flare-up of COVID-19. Now, because currently the infection rates, as I said, is at a low rate, and we're shifting to a more endemic pattern, where we have also shifted our daily reporting to now weekly reporting, as we do with other respiratory illnesses such as influenza. In addition, we have stopped reporting on COVID-19 antigen testing because of poor data quality from antigen testing. This allows us more robust estimation of trends rather than when small daily numbers are followed, which are affected by small fluctuations. So but on a national level, I want to assure South Africans that we are continuing to monitor working with our National Institute of Communicable Diseases. The NSID is still continue on the surveillance and gives us surveillance reports. The ongoing monitoring of genomic data is also managed by our network of genomic surveillance, and this includes monitoring of the emergence of variants and lineages from tested patients and wastewater. Now, in the last few months, there have been some identification of some different variants, but what is comforting is that none of these have proven to be much of significance, and the pattern has not changed. So the two subvariants, which is a BA4 and BA5, are still the dominant ones in South Africa, as we see also from reports from various parts of the world that the BA4 and BA5 remain dominant. So at this stage, there hasn't been a variant of significance, of variant of concern, which in any part in South Africa and any part of the world. Some parts of the world have reported some indication of some severe illnesses as a result of the BA4 and BA5, but generally the pattern has remained the same in terms of high numbers, but reduced severity. As far as the vaccination is concerned, I just want to state again that vaccination has proven to be very effective. Even in our country, as we have indicated, even when the BA4 and BA5 have been flaring up in various parts of the country, it has proven beyond any doubt that with vaccination, most of the people have had very mild illnesses. And at this stage, I can also say that I'm one of those who can attest, because we did announce on the 19th July that I also tested positive, but it's very mild and only lasted for about 4 days. And as a result of that, one was able in the following week to be fully at work. The vaccination has been, struggling. On average, on a weekday, we see just around 11,000, 12,000, most of which are boosters. But we're very happy that there's still new takers of the vaccination. We would have still wished for a much more uptake because we still have the capacity. We know that some of the private vaccination sites have scaled down because of low uptake, but the public sector, vaccination sites are still, are now linked to our normal, health provision sites, our primary health centers, and also at hospitals. At the current moment, there hasn't been much movement in terms of doses administered, just over 37.3 million. We're pleased that our over 60 population has passed 70%. We remember that our aim was to cover 70% of the adult population. We're happy that the over 60s are standing at 71.4% of vaccination. Our Vaccination Ministerial Advisory Committee is now considering vaccination of children. Thus far, what they've recommended is that only children who are immunocompromised should be considered for vaccination, not those who are healthy. At this stage, it's not recommended that they should be vaccinated. So we're working on the logistics for this, because there are a number of factors which needs to be put in place in order to make sure that the children between 5 and 11 can actually be vaccinated. Let me touch briefly again, just to emphasize that we want to again encourage South Africans to be vaccinated against COVID, because even though the infection rates are low, severity is low, we don't know what variants will be coming, and it has shown that even with variants, the vaccination is still very effective. Just very briefly on the adverse effects of vaccination, we reported through, and SAPRA did report that there is a confirmed case of a patient who succumbed to Guillain-Barré syndrome, which has been positively linked to vaccination of the Janssen vaccine. Now, this is a very rare but severe event that is associated with administration of various vaccines and medicines. It can also be triggered by the COVID-19 infection itself. But in this case, it has been positively associated with the Janssen vaccine. This is a rare condition, as I've indicated, which leads to paralysis, which can also lead to need for ventilation, which was the case in this particular case. The patient was admitted to hospital, ICU, but unfortunately succumbed to the Guillain-Barré syndrome. Now, the investigations are still continuing to look at other reported cases of severe adverse effects, and the team which is working on this, which reports to SAPRA, will indicate if there are any other situations where such severe effect of vaccination have resulted in severe disability. Now, we'll remember that we did establish the no-fault compensation scheme. So in a case where this causality is established between a severe illness, including death, we have now the full panel, which is looking at all these reports to adjudicate cases which are being referred to the NISEC, which is the team of experts which is looking at all these reports. There are currently 75 cases which have been referred from the NISEC, which will be considered by the adjudication panel, and where causality is confirmed and adverse effects has led to a certain form of disability or severe illness, the no-fault compensation scheme will then kick in. Just lastly, in brief, on the 29th of July up to the 2nd of August, a delegation of South Africans under the auspices of the Ministry of Health and Department and SANAC, which was coordinating, the South African National AIDS Council was coordinating, we attended the International AIDS Conference in Montreal, Canada. Now, this was happening, is the first in-person International AIDS Conference since 2018 due to the effect of the pandemic, of the COVID-19 pandemic. Now, so thousands of representatives from governments, from civil society, scientists, researchers, all assembled in Montreal to look at the number of issues in relation to the management and the control of AIDS, HIV. We know that through the United Nations and through UNAIDS, all of us, members of the UN and WHO, have committed to the eradication of AIDS as a public health threat by 2030. And a number of milestones which we have agreed upon, first of which is the 1990, which says that we must have all countries by 2020. So many of us have already missed this because of the COVID, that in all our countries, 90% of people living with HIV must know their status. 90% of those who know their status must be treated, must be on treatment, and 90% of those on treatment must be virally suppressed. The next target is the 95-95 by 2025. So this conference was looking at this again to see where we are, where the world is in terms of this, and also looking at various interventions. The theme of the conference was that we must recommit, but also we must follow the science. So a number of scientific developments were also on display and reported. Amongst the things which were really countries were urged to do was, amongst others, to implement the pre-exposure prophylaxis for HIV, especially for the population at risk, such as sex workers, but also in terms of young girls and adolescents, those at risk. But also, and there was also a call by a number of participants to also look at new scientific methods, such as the piperidine ring, but also to look at the long-term injectables, which can also be able to make sure that we can have a better control. So on the one side, we're looking at the biomedical side, that all of us must look at the science, but also a number of scientists, including our own scientists. Professor Glenda Gray was one of the presenters who presented also the progress which is being made in as far as vaccination for HIV and AIDS. Let me leave it there, facilitator, so that our team can also, of experts, can also add on some of these matters. Thank you very much.
Thanks, Honorable Minister, for that comprehensive update as far as COVID, monkeypox, and all other health issues is concerned. At this point in time, I'm going to call upon our scientist, Dr. Michelle Kurum from the NICD, to provide us with the epidemiological report as far as monkeypox and COVID-19 are concerned. Over to you, Doc.
Thanks, Foster. Can I just confirm you can see my screen?
Yes, it's visible.
Thanks. So good morning, everyone. Honourable Minister, Deputy Minister, colleagues and members of the media and public. So just to give you an update firstly on the COVID-19 pandemic, just in terms of global, this is really just showing the cases on the top and the deaths on the bottom, and you can really see that in terms, especially in the number of deaths, that this is the lowest point at any time during the pandemic. Some countries have seen a few resurgences in the last weeks, as we did, mostly driven by BA4 and 5. And while I think different countries have different levels of immunity, different levels of prior infection and vaccination, so quite difficult to compare different countries. But overall, globally, in the last week, we have been seeing a decrease. If we look at South Africa, this is in terms of our laboratory confirmed case incidents. You can see this is where we lifted our restrictions. Already at that time, we'd been seeing a decrease in the number of cases. And since we've lifted the restrictions, these case numbers have continued to decrease in all age groups. If we have a look at the number of hospitalizations and deaths, so on the left-hand side is our incidence of hospitalizations. Once again, this was with our last surge due to the BA4 and 5. This was when the deaths, the hospitalizations were on their way down when we lifted restrictions, and very, very low numbers of hospitalizations. And similarly for deaths, we have seen as the pandemic has progressed, there's been this uncoupling between cases and hospitalizations and deaths. Very low number of deaths with this last resurgence due to BA4.5 and continued declining deaths once the restrictions were lifted in June. We continue monitoring for new variants of concern through our sequencing, and you can see very low number of sequences at the moment in terms of because there's a low number of tests and low number of cases at the moment, and so we do have a low number of sequences that are being tested, but this is predominantly BA4 and 5. There have been a few additional sequences of a new sequence, but very low numbers. And this hasn't translated into any increases in cases or hospitalizations. So really, since lifting of the restrictions, the number of tests, cases, hospitalizations, and deaths have continued to decline. As the Minister indicated, we have now moved to weekly reporting. And really, this is because COVID-19, the numbers are really at low levels. We're seeing the shift to a more endemic pattern. And so for other respiratory illnesses like influenza, we are usually providing weekly updates in the season. And so we will continue to monitor that. But at the moment, weekly reporting is what is indicated. And this really allows us to get a better estimation of the trends over time. I think throughout the pandemic, we've never had any public health impacts based on the daily numbers, because there is fluctuation from day to day. And so all through the pandemic, our weekly trends are really what is important in terms of monitoring. Just to reassure everyone that the NICD, although we are only putting out weekly reports, we are monitoring on an ongoing basis to detect any signals of increasing cases, hospitalizations, or deaths. And we are actively continuing our genomic surveillance, looking for these new variants. We're testing samples that we're getting from people who are testing, as well as from wastewater surveillance. And really, to reiterate that vaccination still is the most important way to maintain immunity against severe infection. We have a lot of underlying immunity in South Africa, both through vaccination and through prior infection, but it's less certain about how long this will last. And with very low numbers of infections at the moment, you may not be boosting from infection. And so very important that we continue to boost from vaccination. And especially for those high-risk groups, we know that the elderly, even those over 50, are at high risk, those that are immunocompromised and with underlying conditions. So really just to encourage those who have not received their boosters to really receive their boosters now. And just to provide the link for our reporting, that you're able to access our weekly reports. Just moving on to monkeypox, just a few points to highlight that this is a viral disease. It's a zoonotic disease, which means that it's come from an animal population and originally originates from areas in Central West Africa. And in past years, it's endemic in these countries, and there have been occasional cases in other countries, and mainly due to travelers who are traveling to these areas, being exposed and then going back to their countries. The current outbreak is now the largest, and this has developed since May 2022, with almost 30,000 cases reported from 89 countries from all WHO regions. And this is why we're concerned with monkeypox at the moment. Monkeypox has always been around, but it's been these more sporadic cases. And so it is unusual that we have seen so many countries affected with monkeypox. And this is why the DG of the WHO declared it a public health emergency of international concern. And the main reason for this is because it is a new disease, or a disease that has spread into new areas. And it's really important to keep a handle on how it is progressing. So just quickly, in our context, the virus is entering usually through broken skin, the respiratory tract, mucous membranes. And in South Africa, it's most likely that it's person-to-person transmission through very close contact. So firstly, it is not in our animal populations, and so we are not getting it from the animal sources. So there's no risk in terms of contact with animals. So for us, it's person-to-person spread and very close contact. So we're used to COVID in terms of what we meant by close contact with COVID, but with monkeypox, this is skin-to-skin contact. So it is not just being in the same room with someone as we had with COVID. Materials contaminated with the virus can also spread it. So usually it presents with a typical viral picture with fever, headache, body aches. Very classic is enlarged glands or lymph nodes. And then you get a blister-like rash, okay, which is very much like other rashes, something like chickenpox. There are some differences, and on our website for clinicians, we do have some guidance in terms of how to differentiate between the different rashes. It's usually self-resolving, which means it gets better on its own, lasts about 2 to 4 weeks, and you may just need symptomatic treatment to control the fever. The severe cases from countries, the endemic countries in Africa, children and pregnant women, and those with underlying immune deficiencies where they saw severe cases, and you may get a small number that have complications, but rarely fatal, so there are not a lot of deaths. Once again, we have a lot of information on our website if you would like to access this information. I just wanted to present some of the global data. I think it's important just to highlight what is happening elsewhere in the world, and this is from the most recent World Health Organization report, which is also publicly available. So almost 30, so this was up until the 7th of August, where there was close to 30,000 laboratory confirmed cases and 11 deaths. And you can really see that this is mainly in the European region and in the region of the Americas. And the deaths, 7 were from the Africa region, and then the other 4 deaths were from other countries. Also, just to look, it's important to look at the epidemiology of what's happening in globally. And 99% of participants who are testing positive are, well, not participants, of patients, are males with a median age of 36 years. The range is males from 18 to 44 years. And this population is disproportionately affected, which means that the majority, 70% of the cases, are males in this age group, 18 to 44. Less than 1% of cases are in the under 18 years. There have been a few cases in families where there have been transmission to other family members, but this is in the minority. And in those with a known HIV status, around 40% are HIV positive. There have been some cases in healthcare workers, 344 cases, but most of these are actually being infected in the community rather than in the health system. And there's only been 1 health-associated infection. And you can see most of the modes of transmission are through sexual encounters and person-to-person contact. Okay, and so this really is the close contact that is resulting in the transmission. And really to highlight as well, with the exception of the countries in the African region, the ongoing outbreak is primarily affecting men who have sex with men and who have reported recent sex with 1 or multiple partners. In South Africa, monkeypox has never been recorded in South Africa before June of this year. And subsequently, we have 5 cases which we believe are unlinked. They have all been in males aged 28 to 42, 2 were from Gauteng, 2 from the Western Cape, and 1 from Limpopo. And either had travel history or had contact with someone who may have had travel history. And 1 was a tourist who had returned home. And for the first 3 cases, we've instituted contact tracing of the close contacts. This was completed. None of the contacts had reported any symptoms, and they fully recovered. And with our 2 recent cases reported this week, we are continuing with contact tracing of the close contacts, and the cases are busy isolating at home. I think for South Africa, currently for the general population, monkeypox is considered low risk. Our public health response is really in terms of contact tracing and monitoring of the contacts. There's no isolation of contacts. There's just isolation of the positive cases. The high-risk population, and I think we are falling into the category of the European countries, which are non-endemic countries where monkeypox has not occurred in the past. And really these, as according to the epidemiology that we've seen, are mostly men who have sex with men. There's a positive travel history, and our laboratory staff are also at high risk, so those that are doing the testing. Smallpox vaccine was given just until around 1980, and so for those of us who are older than 40 years, this does give some cross-protection against monkeypox, but currently, as Minister indicated, there are no vaccines or antivirals licensed currently in South Africa. And as Minister indicated, those talks are ongoing in terms of moving forward with possible vaccines and antivirals. So I think really just to consult your doctor if you have any symptoms suggestive of monkeypox, if you consider yourself to be at high risk. There's testing available both at the NICD as well as at private laboratories. And I think just to stress that testing is really important so that we can understand what is happening with the disease. This is a new disease in our country, and the more we know about where this disease is occurring, who are at-risk populations, it makes it really easier to be able to know where to put our public health actions, who needs to access vaccines. And so really important that people who do feel that at risk, do have symptoms suggestive of monkeypox, to really access testing. So I think I'll stop there and hand over back to the Minister.
Thanks, Dr. Michelle Groom, for that comprehensive epidemiological report. I'm not sure, before I take the media interviews, questions, any comments, inputs from the team, from NICD and the department, Dr. Chris, Dr. Jacqueline West, any comment, input from the team?
Good morning, everyone. No, I'm ready to answer questions at this stage. Thank you.
Okay.
Thank you, Foster. Nothing more from me. I'll also be happy to answer questions. Thanks.
Okay. Thanks very much, Minister. Thanks very much to Dr. Groom. So far, we've got very few questions that I'm going to quickly go through. Let me do like this. The first batch of questions reads as follows. The first question is directed to Minister of Health from Christian from Network 24, which reads as follows. What would the Minister of Health advise men who are having sex with men in relation to monkeypox? Second question, which is a follow-up question, is there a need for this group, MSMs, to be vaccinated? Question number 3, now that we know which countries have higher number of monkeypox cases, are we going to have targeted screening activities on people arriving from those countries? Question number 4, can someone with suspected symptoms of monkeypox go to private healthcare laboratory or doctor to be tested without incurring any cost? Question number 5, what is the isolation period for monkeypox? Question number 6, which is the last question, with the first reported case of human to a dog transmission, should we be communicating this to the public? What is IPC measures? What IPC measures should be communicated? I'm not sure if the panelists and the supporting panelists have got the questions. Minister?
Was that last one? Just repeat the last one. Number 6.
The number 6 is saying, with the first reported case of human to a dog transmission, a dog, yes. With the first report,
I'm
case.
Not familiar with that. Maybe the NICD team can help us. Okay. Yeah. Okay.
So should we be communicating this to the public? What IPC measures should be communicating?
So the questioner is suggesting that there's a reported case of a monkeypox transmission from a human to a dog.
Yes, that's my interpretation of the question.
I'm not familiar. Okay, I think we leave that to our team. Okay, let me just deal with the first one and the follow up to that, but I'll also ask other colleagues they can come in and add on to that. In terms of the available information, one would say that firstly, as already indicated, I mean, it's been spelled out from the WHO in terms of the epidemiological reports, but our Michelle has also emphasized the same point from the available data. So it is quite clear that at this stage, in terms of the dominant spread is amongst the men who have sex with men. So it just means that in terms of that community, there has to be utmost vigilance in terms of any symptoms, the symptoms which have been stated by Dr. Michelle Groom, the fever, rash, lymph nodes, all those, symptoms and signs which have been spelled out. It means absolute vigilance in terms of that population community. But also at this stage, we can see in our country that the numbers are still low and the trend is associated with traveling. So it's again, I think, just to say that within that community, as people travel, especially to the Americas and Europe, because that's where that's far the spread has been. Our colleagues in that community should be absolutely vigilant when they do travel, when they do interact with people who come from those countries where the numbers are quite high. Now, the second follow-up is whether there is a need that, especially in this group, for vaccination. Well, it's something which, as I've said in my introductory remarks, that we're looking at in terms of the epidemiological evolution. It is worrying that in the last, in this last few days, we had a case on the 17th, preceded by one on the 14th. So in a period of 3 days, we had a positive case confirmed. So that is suggesting that we may have to, we may be getting a situation where the frequency is much more increased. So because of that, we will be asking our MEC on vaccines to have a look at the situation, but also, as I've said, keeping in touch with SAPRA to see whether any of those vaccines which are approved elsewhere in the world, including in the European medical authorities, medical medicines authorities, whether some of those, there's applications for registration in South Africa. And as the situation, both the access, the availability, the registration, approval, and also the development of the epidemiological situation, as all those things happen, we will be getting advice from our VMEC so that at the appropriate time, when we see that the risk is rising and also the vaccines are accessible, we will look at the advice from the VMEC whether we should actually go this route. It's possible that maybe in a few months' time, or depending on how the epidemiology evolves, we may actually need to go that direction. There was a question which I also want to quickly deal with so that the other team members can come in, whether, because we know the countries which have higher numbers of cases, we are going to have targeted screening of people arriving. At this stage, we don't have those intentions of targeting arrivals from particular countries. It's only to say that we would encourage, especially South Africans who have traveled to these countries, to be much more vigilant. And if they experience any of the symptoms which have been mentioned, to present themselves to health professionals speedily, so that they can be diagnosed either positive or negative, and start their isolation and treatment as soon as that has been done. But at this stage, we haven't considered, and we are not, it's not on the cards, because even though there's a trend, but nothing close to in relation to what was the situation with COVID in the first, second, and third waves, but also because of the fact that this is not spread through droplets, aerosol, and so on, but more through contacts, direct contact. At this stage, we would not be looking at a specific, screening. The general screening of fever will continue. Our taking of the thermal checks of temperatures at the airports, at the ports of entry, will continue. If somebody is picked up with a fever, they will be asked a few more questions to fill up a questionnaire for more medical information, but there will not be specific target for the European and Americas countries. Let me stop there, Foster, and 2 other or 3 other questions which other colleagues can take up. Thank you. You are muted. You are muted.
Oh, thanks, Miss. Yeah, thanks for that. Those responses, Minister. I'm going to hand over to Dr. Michelle and other colleagues to make inputs on the other questions.
Thanks, Foster. I think I'm going to give Dr. Veya a chance just to weigh in on, she is our monkeypox expert, just to weigh in on some of the questions. Can you just quickly highlight, Foster, which ones are remaining?
Well, there's a question about can someone with symptoms go to a private health practitioner? What is the isolation period? That's the next one. And the last one is the one which I said I have not heard of, transmission from human to a dog. Yeah, those are the three.
Okay, perfect.
Yes, that's
So
correct.
I'll start with those and then Jackie can jump in. So just in terms of the isolation period, so this is usually 6 to 13 days with a range of 5 to 21. And so that's why in terms of isolation, we would recommend that for people who are infected to isolate for 21 days. And then usually you have that kind of rash period with fever, which can last between 0 and 5 days. And then usually between 1 to 3 days later, you'll get the rash 1 to 3 days after the fever. In terms of the testing, private testing is available. As I understand, this would be at a cost. And so I think if it would be similar to with the COVID-19 testing, where through the private laboratories, this would come at a cost. But in terms of the NICD, we are able to do testing through the NICD and do have capacity. And I think Dr. Vaya can speak a little bit more to that. So I'll hand over to Dr. Vaya and also just to speak to the animal transmission as well. Over.
Thank you, Michelle. Yes, so certainly just to highlight that all of the cases that we've diagnosed in South Africa have been, the clinical diagnosis was made in private practice. So these were private healthcare patients. The NICD has been offering testing since May, and recently several private pathology laboratories have also come on board to increase accessibility of testing and rapid testing turnaround times. So we do have fairly good accessibility for lab testing in South Africa, and we do really urge the public, individuals that do feel that they are possibly suffering of monkeypox, to consult with healthcare workers and to access testing if that would be required. In terms of isolation, I also just quickly wanted to add, the infectious period for monkeypox ends when the last lesion has scabbed over. So the blister-like lesion develops a scab as it's resolving. When that scab falls off and the skin is now, a new layer of skin is formed under the scab, you are no longer considered infectious. And then the question about the spillback of monkeypox from humans to animals. So we know that monkeypox virus in nature is maintained in certain animal species. You would then have introduction of the virus into the human population through a spillover event. We can have human-to-human transmission as we are experiencing currently. Now we can add to that chain where humans can become the source of infection to animals. Now we theoretically appreciated that possibility, but there has been no evidence towards the spillback of monkeypox virus from humans to other animals before. So the case that is being referred to is a domestic dog, a pet, in Paris, France, that was diagnosed with monkeypox shortly following, was living in his owners was also diagnosed with monkeypox. So how this can happen, the virus can remain viable on materials like bedding, towels, certainly sharing of food, but again, also skin-to-skin contact. People cuddle their pets, touch their pets in different ways. So certainly this now seems that there is a possibility that monkeypox can be transferred from humans to animals. This is the only report up to date, so it would seem that this is a very rare occurrence. And if you consider the IPC recommendation and the isolation recommendations that we've already issued since early June in South Africa, we do recommend that individuals that have been diagnosed with monkeypox try and isolate themselves from the pets in the home as well. So we appreciated that possible risk, and we already have recommendations to try and limit that type of transmission. Thank you.
Thank you very much, Dr. Weah, for those additional inputs. I've just received the last two questions that I feel I need to touch on them before we close. The latest question is reads as follows: what plans do we have to test for monkeypox in other provinces other than Gauteng, which is already covered? Plans for other provinces in order to test. The other question I see it has been answered. It was a direct question to the panelists. Yeah, maybe colleagues can answer this last question before we wrap up the briefing. Plans for testing in other provinces?
I'll jump in on that. So we do have a national footprint for testing. We have been testing a request from nearly all of the provinces. I don't think we've had requests from the Northern Cape, but we certainly have had requests, I think, from all of the other provinces. So we have a national laboratory footprint through the National Health Laboratory Service. There is a routine referral system in place, which works really well, from all of these laboratories that are distributed throughout the country. Now, in recent weeks, some private laboratory services have come on board as well. And as you very well know, these laboratories also do have a very comprehensive national footprint. So accessibility of testing should not be a problem. Thank you.
You are muted again, Foster.
Technology. Thanks. Yeah, before I hand over to the Director General, Dr. Sandile Utelezi, to do the closing remarks, I'm going to allow Minister Dr. Joe Butler to have the last bite. Over to you, Minister.
Well, thank you very much. Just to thank all the panelists, but the DG will do that. I think my last shot is really just to emphasize again that in as far as the monkeypox, we're monitoring with all our partners, NICD, and we do everything to monitor the evolution of the epidemiology in our country, and we'll keep the public informed. And when also being advised by experts, and as and when it's necessary in terms of vaccination of the population at risk, and when the vaccines are available, we'll be able to communicate that in conjunction with our regulatory authority. Lastly, just to say again, COVID is not over. Its impact is at a low rate. We're all enjoying our freedoms again, but let us remember that the risk is still high, and as already stated, especially those 50 and above, and also younger people who have not been vaccinated. The vaccines are still available, and for our protection, because natural immunity is going to be waning going forward, and it's already waning. So we'll again urge people, those who have not been vaccinated, to come forward, but also those who have had vaccination but not yet had boosters, to go for their boosters so that they can have full protection. Thank you very much, Foster.
Thanks very much, Minister, for that inspiring words. Now I'm going to hand over to the Director General of the Department of Health, Dr. Sandile Utelezi, to do the closing remarks. Over to DG.
Yes, no, thank you very much, Foster. A special word of thanks to our Minister for leading this briefing and ensuring that our public is always on board. Our esteemed panelists, our two colleagues from NICD, Dr. Kroom and Dr. Weah, Dr. Crisp and other colleagues from the department, but more importantly, members of the media, you play a very crucial role in ensuring that public is always on top of things in terms of information. And please keep assisting us with the communication, and we'll always avail information. But once more, we want to stress what the Minister has said, that we still have COVID. We need to take precautions. we are on high alert and we're monitoring monkeypox, COVID, and other communicable diseases. On that note, we wish you a good day and a blessed weekend ahead. Thank you very much.
Thank you very much, Director General. On that note, I'm going to take this opportunity to thank all members of the media who have joined us and also continue to give us a time to raise awareness about this, the monkeypox, COVID-19, and other health issues. So we are going to continuously avail ourselves, avail the Minister, the Deputy Minister, the DG, and other experts in order to continuously remind our people about the dangers associated with these diseases. On that note, I'm going to declare this media briefing adjourned until next time. Thanks.
Thank you very much. Thanks.